Okay, we're going to start. Welcome, welcome, welcome. I'm Peggy Chapman, and we want to welcome you to the New England Parents PANDAS Association from the Northeast. The name is evolving, just in case you get a little confused. It's currently New England PANDAS Parents Association. And my name is Peggy Chapman, and I'm a clinical nurse specialist in psychiatry and child and adolescent psychiatry. I have a private practice in Hingham, Massachusetts, doing psychopharmacology and a lot of cases with pandas. And I'm also the medical advisor to the New England PANDAS Parents Association. And I want to introduce the panel and thank them for being here today. Far left is Dr. Rosario Trifletti, many of you know, from New Jersey. And new to me, and I'm really thrilled to have you here, Dr. Jordy Thompson, who's in Peterborough, correct? New Hampshire. And a very dear person to me, Dr. Paul Hardy, who's in neuroscience. And Dr. Thompson, you're a family medicine? Dr. Trifletti is neurology, and Paul is neurology, behavioral psychiatry. Or do I get that right, after all these years? Paul is also a mentor of mine. For 6 years I worked with him, and he widened my world and challenged me in ways that I sometimes regret, and most of the time welcome in medicine and functional medicine, where you look beyond the symptom to find out what's the cause. That's a basic premise of how I got into things like pandas. We also want to give great thanks to Cortigen Diagnostics, who have a table out here and have information for you, and they have IVIG as a product and infusion services, and the Autism Research Institute. Is anybody here today from that as a sponsor? Okay. Whether you're a parent or a child with pandas and pandas, or a clinician supporting our children, we are hopeful that through the information you're going to hear today, that you receive or share this weekend, it will raise awareness and expand medical care available. I also want to note that today's event is going to be audio recorded and on stream, meaning live stream, to a application, I guess, called Livestream. Adam, is that correct? So be aware of that if you're asking questions or making comments. There will be index cards at the table outside, and we will be coming around to collect them. They've been passed out at all? Any of those? We might want to pass them out on the aisles. So that you can ask questions. Just from great experience using index cards, and they're very helpful when you're a speaker to have them, is try and keep the information concise to the point of the question. We can always expand in discussion. Hopefully we have enough time to answer all questions. But the more personal information you put down, like we're trying to solve a particular problem of yours, it's harder to answer that in terms of lots of detail. And also, as a reminder, to turn all your cell phones off. I think I did mine. To silence them for today. So I'm going to start this afternoon by talking about psychiatric medication, behavioral interventions with children with pandas. Thank you. This goal of this topic is to try and outline for you some ways to communicate with your children, to expand your abilities to help manage your children when they're in the middle of pandas, and to also give clinicians, if they're here, ways to think about pandas in ways that the anxiety, the OCD itself presents itself that may be slightly different than what you're conventionally accustomed to. So I'm going to first start talking about the brain. That's where we're going to center on for pandas. So pandas, as we know it, as best we understand it, is an inflammation of an area, most prominently, although in some of the work of Ditron Angelou of California, the antibodies to strep, in this particular we're talking about strep at the moment, land in a number of places, but predominantly the antibodies land in a place called the basal ganglia. Basal ganglia is not on this picture. Oh yeah, there it is, right there. The center of the brain. And I want you to notice that this center is really center, like if I drew a line right through about right here. And what you don't see are the neuronal tracts that run through this area, all up and down from the spinal cord all the way in, and then stretch themselves out. So what they touch is the frontal, so some of the symptoms, and you see such a wide variety of symptoms, which causes a lot of the confusion of treatment, is the frontal cortex, which is your thinking, learning, and a pleasure spot. The motor cortex, which is right about here, so movement disorders, tics. The sensory part of the brain stems around right here, so you get people who don't want to eat, who gag, who can't put their normal clothes on, who fuss about anything touching them all of a sudden, don't want to be hugged, or they need to be hugged too tight. The parietal and the occipital, which is your smell and your seeing. Right down here is the temporal lobe, which is a great seat of disruptive emotion. And very importantly, and a lot of psychiatry talked about, is the amygdala, which doesn't look like this. It's actually inside, and it's known to be an almond shape. That's what the word amygdala comes from. And it's very much a very important part of fear, flight, also facial recognition. In autism, this is known to be quite different than a typical child. And wrapping around this area is a little horn-shaped area, again, not quite visited on this, called the hippocampus. And the hippocampus is a huge area of study in psychiatry, neurology, neuroscience. It is where short-term memory gets stored and converts to long-term memory. So when you go to bed at night, your hippocampus is being asked to challenge that new information you just learned and flip it into long-term memory if it's got enough exposure. It's also where trauma appears to have a lot of meaning. So it kind of is recording a lot of what's going on, and then how that information gets dispersed through the brain is often in the hippocampal region, the senses, the treatment of that area. So that's a really brief brain biology, but I want you to mostly understand that when the basal ganglia is involved, it has major repercussions throughout. And I know Dr. Terflay and some other people are going to talk more about that later on. Now, explaining PANDAS to your child and to yourself, I find quite a challenge, because that just discussion I had was way too up there, right? Neuroscience. Okay, so I'm trying to get a simplified version for you and your children to understand what is happening to them. So we have germs and viruses and bacteria. Most kids from kindergarten on they know how to wash their hands after they go to the bathroom and before they eat. And germs and bacteria and things are not unforeign, they know about those. And we also say then our body has a highly developed military. Now, this is not the only way you can explain PANDAS, but I think it's a helpful way. The military can be divided into different divisions. So the main divisions are, the first one is the Marine, and that's what you see on your lab results as IgM, Marines. The Marines are always prepared for quick strike. They're always patrolling, head to toe, always looking for the enemy, and they're right there to bang on it when it goes in. And you say to our kids, everything has different bacteria and germs on it, unless they're terribly germphobic. You don't talk about germs a lot. But, this is normal if I scrape my skin and stuff. But those germs are also healthy at certain places on our body. The IgE is the Air Force. The Air Force dive bombs specifically to certain venues, so peanut allergies, seasonal allergies, mosquito bites. So they only take on, the Air Force targets and bombs it. And then you explain to the child that they know about peanut allergies, many of them kindergarten on, because they can't bring peanut butter in their class, or they may have their own allergies, they may have runny eyes, they maybe get Claritin. So they kind of know that pretty well now also at a very young age. But you also can explain that the swelling that occurs with that kind of allergy, their eyes or their nose or their arm, that goes down over time. It's a temporary swelling, because this is important for you and for them to remember that the basal ganglia with swelling, we believe, is a temporary process, although many of you see it dragging on because of chronic exposures to different irritants. The IgA are the boots on the ground always, and I say in the dirt. The IgA patrols in the mucosal system, so eyes, ears, nose, throat, all this is mucosa, all the way down your gut and your bowel and bladder. And most importantly is the Navy, the IgG. IgG is the antibody that floats around in our bloodstream, and it gets there kind of late. So think about any war we're having lately or in the past. The Army the Air Force drops in people, the Marines drop in people, but the Navy generally, except for some of their flights, they have to float there. It takes a while. And in fact, IgG to strep elevates in 4 and 6 weeks and 8 weeks after exposure. So when you do an ASO, anti-streptolysin antibody, it measures IgG, and it's measuring, frequently it peaks ASO about 4 weeks after the infection. DNase, another one, peaks about 8 weeks out. And so some of us are often befuddled because the strep infection or the tiny little sore throat or sniffles your child had May 1st, all of a sudden August 1st you're in deep trouble and have no idea how you got there, because it doesn't always show up as the original Dr. Sweeto NIH definition was that you have a strep throat, you immediately have crazy behavior. That is not always true because of the IgG getting there late. It's the IgG, we believe, that is bombarding the basal ganglia with antibodies. There's a sentiment that the tissue of the basal ganglia resembles strep. So the body gets wrong intelligence. So your kids watch a lot of spy shows, they watch a lot of things. They understand intelligence and spies. So the spies are reporting back incorrectly, and there's wrong intelligence. And as long as that wrong intelligence is going on, they're getting bombarded on their basal ganglia. So you now have the Navy shelling the basal ganglia on a regular basis, and you can point out swelling and how it goes up and down. This is also true in terms of how we understand the medications they're on. The antibiotics are there to protect them from further strep exposure, but also we believe there is, and there's some evidence in other parts of medicine, it's serving as an anti-inflammatory. Now you also know that if some of you call me up and say, oh my gosh, we're in a flare, they're back to the beginning, I'm horrified, you're horrified, but they're on antibiotics. What do? One of the most important things you do immediately is put them on Advil, ibuprofen 3 times a day for their dose weight for about 3 to 5 days, making sure they eat because you don't want to rot their stomach, because it's anti-inflammatory. But as any of you know who are on chronic pain meds, it's not good long term. Prednisone is another medication that some physicians here will use for inflammation, but it also has complexities to it. But it's all about removing and reducing inflammation. So the next part you need to talk about is trying to give an identity to this. As you'll see later, I mentioned that this is like the invasion of the body snatchers to me. You know, you had this child yesterday, and now you have this child, and who the heck is that one over there? So you want to try and give pandas a name. It's not your child, it is something that's occurring to them. And this is out of work given with OCD. So try and name it. You know, if you don't like Uncle Bert is bothering you right now. You know, or some kid came up the other day with some strange thing of a character he didn't like on a cartoon. So, you know, you can say things like, is Bert calling? You know, because you don't have to be overt about it. You can't say, is the pandas bothering you today? And then also accompanying this message, you want to kind of convey in the best language possible that the message you're about to hear is notoriously unreliable, distorted, and out of proportion. Because the message that tells your child they can't go to bed at night except in your bed. The message that they cannot move across the kitchen floor because they cannot move across those lines. The message they cannot eat because they will choke and die. All those messages are unreliable. And I saw a very different source of anxiety, but it really struck me. The author pointed out, based on some what we call mindfulness training, that just because the thought is in our head does not mean it's accurate. But of course we think, because we think it must be. So think about that. You have to way to rethink your thinking, which is just because it's your thought or you're thinking it doesn't mean it's accurate. And again, flares are important to recognize, and they are not all defeating. You will feel like you're back to square one sometimes with a flare. They're usually brief if you're on proper treatment at the time. But it depends on how many kids with strep throat are sitting in the classroom, how much flu mist arrived last week in your classroom, because that's another area we'll talk about, you know, et cetera. Now, when I'm talking about strep, I just want to clarify. But we also know PANS is caused by Lyme, mono, mycoplasma pneumonia, any other viruses or infections that, again, cause an antibody reaction that's misdirected. This is also what all these allergens are about in our society. Many children with rheumatoid arthritis, huge amounts of this going on in our children that didn't used to exist. Type 1 diabetes is a misfiring of the immune system. So also, what are you treating? What are we working on? We're treating your child, but really it's specific to what symptoms they occur. So it can take the place, as you know, anxiety, very generalized, everything's a mess, everything's fearful. Separation, I can't go to school. Is it the school that's a problem? Not usually in PANDAS. It's usually leaving the home, it's leaving the mom, it's leaving the dad, it's leaving a place that they fear something bad will happen, or it's the only place they feel safe. Obsessive compulsive disorder, a thought or an action or both. And I also think we miss a lot of times the fact that when a child is extremely fearful, that we call it, you end up in a psychiatry or psychology office like myself, and you start talking about it as anxiety. But if you really examine it, it's an obsessive anxiety. It's truly an obsession of a fear. So people sometimes miss the OCD as a concept And then they don't label it PANDAS because the rule currently in press is you have to have OCD as a major calling card and then these accompanying issues. But think about the intensity and the repetition. That's obsession. That's an inserted thinking into your head that you're not well in control of, and you're not generating it necessarily. Lots of phobias, fears, multiple things. Tics, which are movement disorders. Again, tics have been well known for years to emanate from the basal ganglia. So that lines right up. Eating disorders, people who all of a sudden are afraid to swallow. A typical anxiety sensation is the tightness in your throat and the difficulty swallowing. But often these kids have sensory issues that are different. Something smells different. You're chewing breakfast too loud. What you're trying to wear in the morning. Sounds, all of a sudden. They don't want the TV on, or they can't have the radio. They have to, a kid this summer had to have the windows up because of the sound of the noise, and of course it was hot, and they didn't always want their air conditioner on. Urinary urgency is really unique to this group. Again, often missed, but it's important to go back in a family history and look for it, because a lot of times people said, they don't have it now, but 3 years ago they had this bout of needing to pee all the time, and it just kind of went away after a while. So now you're stretching your idea about how long this illness process may have been occurring. Little boys will trip over the cords to their Xbox to run to the bathroom so they don't piddle in their pants. A lot of kids get in trouble at school because they're always going to the bathroom, and if they have accompanying ADHD, they're thinking they're trying to get out of the classroom. They are trying to get out because they're frightened to death they're going to wet themselves. Some, in fact, do wet themselves during the day, and as many of you know, they have enuretic or wetting events in the night. And they probably have been dry since 3 or 4 or 5 years of age, and now they're 8, 10, 15. Why, what's going on? There was a urologist I still haven't talked to in Boston who told a grandmother of my patient, sore throat, urinary urgency, it goes away in about 3 months. Now, how come he made that connection? I still haven't found out. But for that child, 3 months was not going to be easy to manage, and we interceded so that didn't happen. But that's what his opinion was, is you can wait this out for 3 months. And traditional treatments, like cutting down a liquid, getting them up in the middle of the night, parents described to me they soak through their pull-ups that you now start wearing at age 10. So again, just to remind you of the limbic system, and we're going to go into some definitions of anxiety, and I'm not going to belabor a lot of this, but basically try and separate what is anxiety. It's a descent system to perceive threat or danger. It's a very natural core feature of your brainstem and your whole biology from generations and genetics from ages ago. So it's a lot of perceived, and it often translates to physical anxiety. I'll talk about in a minute. The emotion is the chemical emotional changes that go along with that, changes in norepinephrine, serotonin, dopamine, and other chemistries. Affect, when I say how's their affect, or I'm asking about affect, or I'm thinking or writing about affect, I'm looking at you and recording what you look like. Are you sad? Are you happy? Are you frightened? That's affect, what I register that you have. I don't register my own affect. I might say, I think I look happy or sad. Fear, in particular, which accompanies anxiety, is a direct focused response to a specific object. So some of the fears I hear about, which are kind of strange but scary, kids who all of a sudden aren't sure their mother is their mother, their house is their house, their arm is their arm. That's called dissociative experience. But it's terrible. These kids are looking at their mothers. I have one kid who still fears his mother is some devil every so often. And asking, are you going to kill me? I've heard this in the last 6 months twice from kids, which is so sad. But it is specifically about something that will happen. And I want to say that it appears to be very high in PANDAS, specifically. And again, from a child who hasn't necessarily had. Now, when you have a child who's had a history of anxiety, let's say they had a generalized anxiety, they had a little trouble going to kindergarten, first grade, on your kneecap, that is still a whole different level difference of the intensity and the scope when PANDAS enters the room. Now, as I mentioned earlier, the fear, flight, fight, anxiety is fight or flight. So sometimes your children can get very aggressive. They're kicking, they're screaming, they're throwing a massive temper tantrum on the floor. They might be assaulting you. And sometimes it's running out onto the street. This happens not infrequently, especially at night. And they seem to be extremely hyper-aroused heading into bedtime. And then they have the physical symptoms to recognize: heart racing, eyes are dilated or very shrunken, Their breathing rate increases. They're tense, so that's why they're pacing and coming out of their room every 2 minutes asking for something. Their blood flows to the large groups, so that leaves their stomach. They develop a stomach ache. This happens in the morning all the time on the way to school, right? Now, there are many measurements clinicians like I can use. There's about 70 different ones, so if you're in a clinician's office, there's usually a standard kind of review they do about anxiety. Many of these are available on the web. As I mentioned, also in more extreme cases, GI can cause diarrhea, vomiting, tingling in your hands and face and feet. People forget that this happens. You might see them stamping their feet. That's because their blood has gone to major muscle groups, leaving their stomach and their little tiny capillaries in their hands. Tightening, feeling like I'm going to have a heart attack, a weight on my chest. More people end up in the emergency room with heart, chest pain behaviors, far more from anxiety than from true heart illness. Now, panic is the extreme form, which is where you feel like I always say to kids, do you ever have this experience where you feel like you got to get the hell out or you're going to go crazy? And they go, or the parent goes, yeah. You recognize that. That's another higher level of fear, where you literally feel like you're jumping out of your skin if something doesn't change quick. This is where kids at school get frightened because they feel this in the classroom, and unless we offer them a mechanism of relief and escape, which is they can leave the class without hanging their hand up, waiting for somebody to call on them, with guidance, they go to the guidance office or the nurse's office, but they feel trapped. I have a lot of adolescents with not PANDAS, but just anxiety disorders. This is a whole technique we use to get them out of the classroom. If they feel there's an escape route, they're always managing. Problem with at night is there's really no escape route other than to your bed, right? And that's what a lot of times happens. The ironic part about panic and high anxiety is it actually has a very determined physiology with it. It comes up, it peaks, and it goes down, and that process takes 15, 20 minutes. If you ever go to a stop sign and had to hit the brakes quick because someone ran a red light in front of you, you know you're shaking and you're kind of wired for about 20 or 30 minutes. That is the adrenaline surge and slow down. Now, in a lot of PANDAS and a lot of anxiety disorders, sometimes that stimulus just doesn't stop, and this is where you see them in full-blown panic, or this is where you often end up in emergency rooms when you have this ongoing panic disorder where they're literally climbing the walls, climbing you, attacking you. Remember, when they're attacking you, it's the relief of the anxiety that they're trying to achieve. A difference between, for clinicians again, and also parents, between a typical anxiety child, a typical OCD child, is that they can be very overwhelmed by it, but they're usually able to talk about it and describe it with a clinician that knows the questions to ask. Or if you look and you get a book on OCD or anxiety, you will have questions to ask how you treat your child. One of the major differences I noticed over time, and the other clinicians can comment, is these kids have a hard time talking about it. They always look like a deer in the headlights sitting in my room frozen. I never let the parent bring the child the first time. That's standard practice in child-child, but particularly for this group, because you need to describe to me in detail what is going on, and to say it in front of them is horrifying for them. Remember, this is a body snatcher experience. They were somebody else 3 weeks ago, 3 months ago, 2 years ago. They know they were somebody else. So it's really striking, this core difference between a generalized anxiety and an OCD kind of. Now, OCD can be terribly disabling. You can't get out of the bathroom, you can't get out of the bedroom. But believe me, the difference in how a child can experience it, relate it, and talk about it is very notably different. Now, there are PANDAS kids that are better at this, and they can talk about it, and some are online talking to each other. But the majority of them, in my experience, are these kind of frozen faces, and they'll kind of agree that that's been happening to them if I describe what I know. I try not to make them describe it all over again, because I think that's traumatizing, as long as I know accurately and kind of can base out and fill it in a little bit when they're there in the room. Some helpful maneuvers when a child is in an anxiety panic attack is to say things like, this feels really bad right now, or I think anyone would feel upset in this situation, trying to normalize it. Validating, it seems right that nothing you do can help it right now. And manageable, trying to break it out. How big does this feel? Again, by naming it and measuring it. Is this a 1 to 3, a 3 to 5, 5 to 7, 7 to 10? Pre-identify when you're not in your anxiety, what's a 10, what's a 1, what's a 5? And people often ask this in clinics too. Well, how much do you think your anxiety was? Kids with anxiety disorders are often taught how to measure their thermometer across the floor. You know, they set out a thermometer and are you at a 98, a 99, 100? Good news is what goes up must come down, and that's true in anxiety. And it starts with a big feeling, that surge, and then it goes back down and then to more manageable. Common triggers to pay attention to, and parents have confirmed this over and over again with any kid, but also with PANDAS: fatigue, poor diet, some of them have poor diets to begin with, overstimulation. But the biggest stimulant and trigger in PANDAS is the neurology that's going on that people don't have much control over. Now this is really important for you and for your child, but particularly for you. Your heart is pounding because you are upset, not because you have to do something quickly. Now this is the same thing I teach parents who are enraged at their adolescents when they're acting out. But just because you're anxious and your heart is pounding does not equal, I've got to do something. I mean, I can't tell you how many times I got phone calls and the kid, I can hear him screaming in the background because they have to go Build-A-Bear. Well, we're not going to go Build-A-Bear. But they've already told me they got the ferret last week. Now they go Build-A-Bear this week. It's like, hold on, step back, calm down. Just because they're outrageously anxious, and you are, doesn't mean an action has to take place of that magnitude. And most importantly, reasoning, as many of you have tried, does not work. Can we think of your choices to help you fix this? Can we move on? What activity can we switch to do right now? What needs to happen so we can move on? This is common language used in treatment and work with anxiety, and hopefully you can practice this. Now there are total meltdowns, yes. So this is adapted from Tony Atwood, who's an expert in Asperger, and Asperger kids are really, really good at total meltdowns. They are so ridden with anxiety. So this is where you have to kind of change your empathic stance to be a little more distant. You stay calm and reassuring. You stay with them, but don't try and touch them, don't try and hug them, don't try and move them, unless they're in danger. Do not ask what is causing the distress. That is not going to be explained. When you're at the height of panic, your frontal cortex shuts down. You cannot think and reason. Do not try and fix the problem. Do not move too close. Briefly explain that the feeling will go away. So I'm sitting, I'm talking quietly to this mess on my floor, and minimal conversation and distraction. Remember, it has a life. That adrenaline surge comes up and it comes down. So when they're in a major panic attack, you really can't do much but be there and be assuring. But to try and reason, talk it through, that is so beyond their cognitive capacity at the moment they're in this mess. So try not to bother, because you'll just feel frustrated and you intensively keep telling yourself, I'm not doing the right thing. And then you're feeling badly and you're feeling like failing as a parent when you're not. You cannot go up against a tiger and win. When your children are in a panic attack, they are the tiger. They are ready to pounce or run. Now, OCD, I mentioned earlier a little bit, just these are common things that come with OCD. Fears of things will happen, this is leaving the house, the boogeyman that's out in the yard might come in at night. Confess, tell. I have some PANDAS kids who have to tell their parents everything, and often it's one parent who gets very beleaguered by being the receptor of all that news. Saving, hoarding. I don't see that quite as much in PANDAS, actually. It's more of a typical OCD thing, though. Moral dilemmas, religious preoccupations, sexual and forbidden thoughts. Not uncommon in PANDAS, and true in OCD as well. It has to be just right. I have to do it not 10 times, but until it feels right. So there's no known endpoint. Magical thinking, colors, words, numbers will have an effect on me. Compulsions are the actions. So those were the thoughts, these are the actions. They don't always connect. You can have obsessions. People will do compulsions and they don't recognize there's a thought behind it, but usually when you've done an action, there was a propelling thought before you did a hand wash or before you checked or counted. So in OCD with kids, again, it becomes often very quick, very extreme, and it can take all sorts of forms, and it's often in a way you don't recognize your child at all. Now, there's a very formal, very good measure for this called the Child-Yale-Brown Obsessive Compulsions Evaluation, the CY box. For a clinician, it helps measure not only what is their obsession, what is their compulsion, but also how much it is interfering with your life. You could have an obsession to wash your hands, but if you get back to your desk and do your job, who cares? But this is where you can measure not just what it is, but how much it interferes. It's very helpful because it divides into subclinical, mild, moderate, severe, and extreme. And then you can track that. If you're in a moderate to high traditional OCD child, you probably could benefit from medication along with your therapy. If you're in a low, moderate to mild, therapy alone might do it. It's just a longer road if you're doing just a moderate or higher. Severe and extreme definitely usually need medication. Now, Medications, whatever I say now about traditional OCD is not always applicable fully to the PANDAS kid. For minutes, I'll talk about in a minute. This is from a book about OCD and treating children. Step back and get perspective. Catch yourself in the act of aiding and abetting the OCD. Recognize unsustainable commitments, like last week it was the ferret, now this week it's the Build-A-Bear. What is it going to be next week? Actually, I know a parent who bought an ATV for their child when they were in this state. My rule was taught to me by very helpful nurses who criticized me in a nice, kind way when I was floating to an OCD unit one year. And they said, Peggy, here's what you do. When that person asks you their worry question, you get 3 strikes and then you're out. If you answer them more than 3 times, you are now part of the loop of their OCD. So now, there are times when you literally cannot do anything but finish the OCD with your child. I get that. But be aware that when you go over 3 times, whether it's answering, listening, moving, buying, arranging, you are now part of their loop of relieving the OCD, anxiety, phobia. Get that? Okay, so think in rules of 3. Stabilization includes medication, maybe reduced expectations at home and school. If the child comes home and they're obsessive compulsive about perfection, getting their homework done, 4 hours later they probably have not finished. So you may need to modify with school the amount that you can do. You have to sign off and say that's all we're doing and set the limit. I have a couple early adolescents who are into this with their OCD PANDAS. That, they can't let it go, and the parent has to fight with them all night both to get it done, but also they have to just say, time's up, we're done. Communication, a traditional treatment for the exposure therapy is when I have an action or a worry, then the therapist works with the child and the family to plan at the very small level, what can we take on, what can we challenge, what can we do, can we touch this, can we look at it, can we move it? And then they build up over time to the very high level intensities. So exposure therapy is that work. And the readiness for exposure therapy, which is important in PANDAS, is can you change the child? Can you persuade them to try something? Very tiny, maybe with a bribe, but can you try it? And can the child be a vital partner in the treatment? Now, this is where the fallout happens with PANDAS. You hear a lot about it, they need CBT. I don't disagree with that. But when your child is in a major flare and they're chronically in an anxiety panic state, they cannot do the cognitive work that it takes to do CBT. It may be that they just have to show up in the therapist's office and get to know them. But the work of exposure is to make them more anxious to tolerate it and then to learn that they can live through it. So in the kids who are the PANDAS group, I don't push therapy necessarily right away. And I know this causes some controversy. And I know it's very effective when the child is able to do it. But there are times when I don't find you can communicate at all. I mean, a child who just stares at you when you're talking about PANDAS with a therapist, how can they identify what they're going to work on? They can't even talk about it. So there isn't a level which you have to get to in order to execute CBT. But you shouldn't ignore it as a helpful option, both in learning how to manage anxiety, helping you to learn how to manage the anxiety and OCD is critical. It may be the child who's the last on the list to get the help from the therapist. I mentioned that already, the insight. And again, on the OCD, it's not you're a child with OCD, not you have OCD, and that's the only thing we're working on here. Tics are the motor movements. I mentioned basal ganglia is a source of tics. Sorry, I got to check my time here. Okay. So they're movement disorders. They also can be vocal, throat clearing. People forget humming. Throat clearing is often a tic. There is a really good tic scale as well by Yale that you can look up and you can measure. They can be suppressed but not denied. So this is where you see the kids ticking all the way to school, then they shut up and go into school. You hear nothing about it during school. They come home and they tick all evening because they have suppressed it. They don't want to be sound making and psh, 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 Star Wars sounds in the middle of English class. But they will push on it and they will wait until they get home. And then you think they're really sick. How can they do this? They suppressed it during school and then they have to let it out when they get home. This is true of tic disorder as well as PANDAS tics. Here's some ideas about tic support. And just as a note, in traditional psychiatry, if you have a tic disorder, simple motor tic or complex, which would be Tourette's, it's frequently in a person that also may have ADHD or OCD. There's a biology that connects all this, and guess what? When they screen brains of adults with OCD and tic disorders, the basal ganglia is enlarged. Now, they haven't done that work on children so much yet. There is one study, I think, that's come out now. But the point is, why is it enlarged? Usually that means there's some kind of swelling or some action, reaction, something going on. And they've known that for years, by the way. Treatment for tics is often you can't do much because they're not too bad, or there are medications, which are listed later, that you can use to help them, particularly what they call alpha agonists. Those are medications like 10X, clonidine, guanfacine is another name for those two. And also there's a different therapy called reverse habit therapy. Problematic is that there are very many therapists around who can do it. Now, just briefly, I'm not going to have a lot of time to go over the section on medication, and you can read that, but I want to just explain some biology that's important for medication. Most medications, what we're doing is we're manipulating the chemistry that's already there. So these little round things could be called serotonin, dopamine, norepinephrine. Dopamine is the main chemistry of attention, focus, pleasure, and learning. It's very active in the frontal cortex. Serotonin is mood, happy, sad. Norepinephrine is anxiety and learning and focus. So most medications like SSRIs, selective serotonin reuptake inhibitor. This is a reuptake pump right here. And I'm blocking that pump so that more can stay here and more can go to the next cell. In ADHD and in depression, a lot of things I'm medicating for, this section down here is bereft. It doesn't have all those little chemicals, and therefore the next cell is saying, where are you? Come on, give me more. Builds up excess receptor sites like a string of pearls along here, looking for more. And why don't you have any? Could be genetics. It could be you have a serotonin transporter problem. You could have a dopamine transporter problem. You may be low in zinc, which helps dopamine release. In PANDAS, that chemistry we're not clear is messed up. And in fact, how many of you children have had a Cunningham panel? Any of you? So this is Madeline Cunningham's work. One thing she measures is dopamine antagonists. There's something attacking receptors, the dopamine receptor. There's an antibody that she measures that's attacking those receptors. So it's not the dopamine that's necessarily unavailable. It may be the receptors that are messed up. And this is why you don't see classic reactions to these meds. When you put a kid who's all of a sudden developed inattentiveness or ill focus with PANDAS and you give them a stimulant, you just flood them with dopamine and you get all the traditional side effects: anxiety, trouble sleeping, trouble eating, gonna tear my skin out because I'm so, like, you gave me 6 cups of coffee in 2 minutes. This is the problem, I think, and I'd like more input from anybody else on the table, but this is part of the biology, is that chemistry itself is not necessarily what we're working to fix, but there's something about the way it's all being balanced. In OCD, for years, we've known that the serotonin is really not working correct, and in fact, you use 4 times the amount of serotonin blockade in OCD than you do for depression. If you use Prozac 20 for depression, use 80 for OCD. And that's known to be standard treatment. But when you give a kid who's all of a sudden developed OCD a serotonin drug, you all will tell me you can develop nausea, crazy behavior, headache, they don't feel right, they're tired. All those are the side effects of too much serotonin or serotonin receptors not running the way you want them. So I'm going to let you go through this later. There's a lot of chemistry, and I'm running out of time. So let me just wrap up a little bit. Adrenergic receptors are the ones that involve the basal ganglia a lot. They skip the whole dopamine pathway and they enter down below on the other cell, and they intersect the pathway of signaling in a different way. That's what those are. Those are the drugs that are often used for tics, and also kind of hyper anxiety, because it lowers adrenaline. These are the serotonin reuptake inhibitors. You probably know all these names: Prozac, Zoloft, Luvox. Very few are actually approved for children, but all of them are used. Anxiety medications, again, many of you have had ER visits with the Ativan being given or Benadryl being given. And they can be sedating, but if your child has a bad reaction to Benadryl, they're very highly likely going to have a bad reaction to Ativan. Keep that in mind if you're trying to talk to somebody about medicating. They both agitate quite a bit, a small subset of people, but if your child is in that subset, it could be bad news if you give them an Ativan. You test dose it, you baby dose it. These are some other anti-anxiety medications. This is one of my little joys, and I think, Paul, you might have taught me this. Cyproheptadine for nausea in the morning and sleep. It makes you tired at night, and it helps you eat the next day. And one 4-milligram tablet is magic. And your doctors, this is a really old medication. You can't even get it brand, I don't think. So if you can we just try a little bit of that stuff at night for my nauseous, can't go to school child in the morning, or the child who's refusing to eat or cutting down a lot on their stuff. We have this weird thing in our bodies, except for people like me who are heavy, but thin people, when you don't feed them, they tend to get less hungry. So if you have a child who's normal weight and then they stop eating much, they kind of turn off their appetite, and you want to turn it back on. Sleep medications, they're listed here, but frankly, only melatonin are the main ones we use in children. The rest are used in adults and very cautiously in children. These are the ones that are used in children a lot because the side effect is sedation. Clonidine, I already mentioned, that's a tic medication as well. And you'll hear a lot of these other ones used. And Benadryl's one on your shelf at home. And not bad. Benadryl's also, if they're having those major meltdowns and they just keep going, have Benadryl in the house as long as they can tolerate it, and give them one if they take it. It knocks out it just makes them tired. They can't keep up a fight if they're dragging. These are medications for tics. Antipsychotics, your children are starting to get a fair amount of, and some of them are warranted. I have a number of kids, about maybe 10-15%, they are psychotic with PANDAS. They see things, they hear things, they see colors, they think you're the devil. They're hearing terrible things. It's just terrible in their heads. And if they end up in a hospital or emergency room, this is maybe something you do need to consider. Again, in tiny doses that we work up. But again, because of the chemistry, they cause a lot of side effects. You've heard of some adjunctive treatments. People are measuring MTHFR, which is about folic acid. And also, let me say that another one that people are talking a lot about, and I personally don't have a lot of experience other than the side effect I hear about, is curcumin, turmeric, Eastern medicine, anti-inflammatories. The few kids I know that have tried it, many of them complain about stomach aches. So I'm looking for anybody to have any data. I cannot find it on child. It's talked about in the adult literature. It's talked about in functional medicine and what we call complementary or alternative medicine. But I don't have any data to tell me what to do with a kid. And so it's anything you do like that, you do gingerly, and you remember that the more supplements you add to the antibiotic, there may be a day your child goes on strike to put anything in their mouth. So you have to be careful you don't just throw a lot of things at them and then end up the fact they won't take anything, because you at least want them to take their antibiotic and their probiotic. Use your OCD medications. Again, notice the dose ranges are huge, and most of them are not. 2 or 3 are indicated by the FDA for children. These are also some real experimental things. NAC is across the counter. That is not a bad idea if you have a lot of anxiety. It's used in hair pulling. It's used in anxiety. It's used in some other ways experimentally in adult anxiety disorders. It's an amino acid. It's what it's what you eat. When you eat a hamburger, you get NAC, but just in a different form. These are sample letters. I noticed mine is out there along with 2 others for schools. You're welcome to also have me email to you if you want. This is what is the NIH listing under PANDAS. And then what I do at the very bottom is I say, this is this child's symptoms using the above list in case they develop others. And then you ask them to notify you with any strep in the classroom. I noticed some schools in Massachusetts now, the nurses are sending out notification that there's strep in the school, and please be aware that this can cause terrible circumstances for other children, such as they can't go to school, they can't think, they can't do their homework, if your child is coming to school with strep. So there's a real encouragement to not send your child to school with feeling punky, because you don't take them to the doctor till 5 o'clock at night, right? I did. Go to school, and then you deal with it when they get home. Now with the viruses out there, people are washing hands more, and they are a little more paying attention to what illness you might be dragging into school. But that's just, 3 months old from the respiratory virus that's out there. Resources are here. Of all the books, Beth Maloney, Child Interrupted, is kind of the go-to book for what, kind of as a parent working your way through the morass of PANDAS treatment. And then the books that I referred to earlier was some of how to manage identity of anxiety, negative thinking, scared and worried, worry. There's some great little kid books for worry. I don't know why that got messed up. If you have tics, there's some helpful evidence online for the Tourette Association. And OCD, there's a lot of stuff. And that's the end of my talk. And I know I didn't spend a lot of time on medications. I can take specific questions if you want later. But the bottom line is they're all appropriate, but to be handled gingerly and to be respectful of the fact that the regular psychology, neurology, biology that we're trying to treat is not necessarily the same in a generalized anxiety or a traditional OCD case as it did with kids with PANDAS, even if the symptoms are the same. There was a lot of discussion at the Providence Conference about my kid has ADHD, or them told now they have ADHD, developed at 12, which is, by the way, not appropriate. But if you give them the traditional ADHD meds, all hell can break loose if you don't know that you're entering a zone that's pretty gray and messy. Okay, so I'm going to stop. And, oh, you know what, Adam, I forgot about your video. So can we do that now? Okay, so we're going to start with a video that was put together by Adam, one of our co-hosts for the conference. And after that, we'll have a parent and child. Is Joey and Mom here somewhere? Oh, am I ahead of myself? Yeah. Sorry. Do I get time? No, Paul is coming next. Yeah. Okay, so we're going to watch a video, and then Paul Hardy will be talking after I, and I'll introduce him at that time.
Are you loading it from there? Okay.
You said you were taping this?
Yes.
Is it going to be on something so we can watch it again?
Yes, it will be at the New England PANDAS Parents Association website.
Okay.
And the earlier talk I did, which is very similar in Providence, is there on YouTube, if you're looking up on YouTube, which goes into more of the medication discussion.
When you came to me with your bad dreams and your belief, was here that I see you've been crying. Seems like everywhere you turn, catastrophe reigns. Who really pop us from the dying? I could hold you in my arms. I could hold you forever. And I could hold you in my arms. Oh, I could hold you forever. Now we see how it is. This fist against this steel. Weapons of war, symptoms of madness. Don't let your eyes refuse to see. Don't let your ears refuse to hear. You ain't never gonna shake this sense of sadness. I could hold you in my arms. I could hold you forever. And I could hold you
I think that's an important message, that no one is alone. I just want to state that because I know I've talked to a couple of you as you came in, and I think that we all feel alone when we start going through this, and Adam and I did very much feel alone, but you're not. And you have some incredible people here that are talking to you tonight. There's, therapists that are here. There's, I talked to a naturopath that's here. There's, there's doctors that are here. They're here to help you, nurses. So I just want to let you know that you're not alone.